the most important previous year and most frequently asked MCQs on upper limb very soon. So please do subscribe our channel in order to get acquainted, and this is a chance where you can evaluate yourself on this topic. We'll be starting our lecture by discussing in detail about the movements of the thumb and the muscle. Now I'll be explaining the functional components of the hand. So this is the radial mobile component, this is the ulnar mobile component, and this is the central fixed component. Now I'll be explaining the movements of the thumb, their plane, and the muscles producing them. So the first movement we'll be seeing is flexion. So this movement shown is flexion and it occurs in the plane of the palm, and the muscles involved is flexor pollicis longus and flexor pollicis brevis and the opponens pollicis. Let us move on to the next movement, which is extension. The movement shown is extension, which occurs in the plane of the palm, and the muscles involved is extensor pollicis longus and extensor pollicis brevis. The next movement we'll be seeing is abduction. So this movement is abduction, which occurs at right angle to the plane of the palm, that is the anterior posterior plane away from the palm, and the muscles involved is abductor pollicis longus and abductor pollicis brevis. Let us move on to the next movement, which is adduction. The movement shown is adduction, which occurs at right angle to the plane of the palm, that is the anterior posterior plane towards the palm, and the muscles involved is adductor pollicis. Let us move on to the next movement, which is opposition. The movement shown is opposition, which occurs across the palm in such a manner that the anterior surface of the tip of the thumb touches in contact with the anterior surface of the tip of the another finger, and the muscles involved is opponens pollicis. To start on with the introduction, the metacarpal of the thumb, that is the first metacarpal, does not lie in the same plane as the metacarpal of the fingers. The movements of the thumb occur in a plane at right angles to the planes of the corresponding movements of the fingers. Now you might wonder what is the reason for this. It is because the thumb is medially rotated through an angle of 90 degrees, and as a result, its extensor surface is directed laterally and not backwards. The movements of the thumb occur at carpometacarpal, metacarpophalangeal, and the interphalangeal joints. This table summarizes the movements of the thumb, their plane, and the muscles producing them, which I have already discussed in detail in the form of a diagram. Please go through this table because it's very important. Let us move on to the next important short answer, which is the extensor retinaculum. This diagram shows the transverse section of forearm just above the wrist. So now I'll be explaining you the structures passing through various compartments beneath the extensor retinaculum of the wrist. So the first compartment includes the abductor pollicis longus and extensor pollicis brevis. The second compartment consists of the extensor carpi radialis brevis and extensor carpi radialis longus. The third compartment includes extensor pollicis longus, and the fourth compartment includes extensor digitorum, extensor indicis, posterior interosseous nerve, and anterior interosseous artery. The fifth compartment includes extensor digiti minimi, and the last compartment, which is the sixth compartment, includes the extensor carpi ulnaris. Under extensor retinaculum, we'll be discussing in detail about its introduction, attachments, compartments, functions, and the structures passing through various compartments beneath the extensor retinaculum of the wrist. To start on with its introduction, the deep fascia on the back of the wrist is thickened to form an oblique fibrous band called the extensor retinaculum, which is directed downward and laterally. To move on to its attachments, the medial end of the extensor retinaculum is attached to the styloid process of the ulna, triquetral, and the pisiform bones. Its lateral end is attached to the lower part of the anterior border of the radius. To move on with the compartments, the space deep to the extensor retinaculum is divided into 6 compartments by 5 septa, extending from the retinaculum to the dorsal aspects of the lower end of the radius and the ulna. To move on with the structures passing through various compartments beneath the extensor retinaculum of the wrist, the first compartment includes abductor pollicis longus and extensor pollicis brevis. The second compartment includes the extensor carpi radialis longus and extensor carpi radialis brevis. The third compartment includes the extensor pollicis longus. The fourth includes extensor digitorum, extensor indicis, posterior interosseous nerve and anterior interosseous artery. The fifth compartment includes the extensor digiti minimi, and the last compartment, which is the sixth compartment, includes the extensor carpi ulnaris. Let us move on to the next important short note, which is the clavicle. Now I will be explaining you the parts of the clavicle. The clavicle consists of three parts: the medial end and the lateral end and a shaft. The lateral end is also called as the acromial end, which is flattened above downward and articulate with the medial margin of the acromion process. The medial end is also called as the sternal end, is enlarged and quadrilateral. It articulates with the clavicular notch of the manubrium sternum. So the shaft is curved and its medial 2/3 is round and convex forward, and its radial 1/3 is flattened and concave forward. The inferior surface of the shaft possesses a small longitudinal groove in its middle third, and this groove is called the subclavian groove or the groove of the subclavius muscle. Now I will be explaining the muscles attached to the clavicle. There are only 5 muscles, which include pectoralis major, sternocleidomastoid, deltoid, trapezius and the subclavius. Under clavicle, we will be discussing in detail about its introduction, functions, peculiarities, parts, muscles and ligaments attached, and its clinical correlation. To start on with its introduction, the clavicle or the collarbone is the long bone with a slight S-shaped curve. It is located horizontally on the anterior aspect of the body at the junction of the root of the neck and the trunk. It articulates medially with the sternum and the first rib cartilage and laterally with the acromion process of the scapula. It is subcutaneous, and so it can be palpated through its entire extent. It is the only bony attachment between the trunk and the upper limb. To move on with its function, it acts as a strut for holding the upper limb far away from the trunk so that it can move freely. It transmits forces from the upper limb to the axial skeleton, that is the sternum. It provides an area for the attachment of the muscles. To look on to its peculiarities, it is the only long bone that lies horizontally and has no medullary cavity. It is subcutaneous throughout its extent and is the first bone to start ossifying between the 5th and the 6th week of the intrauterine life, and the last bone to complete its ossification, that is at 25 years. It is the only long bone that ossifies by 2 primary centers and is the only long bone which ossifies in the membrane except for its medial end, which ossifies in the cartilage. To look on to its parts, the clavicle consists of 3 parts: a medial end and a lateral end and a shaft. The lateral is also called as the acromial end, is flattened above downward and articulate with the medial margin of the acromion process. The medial, also called as the sternal end, is enlarged and quadrilateral. It articulates with the clavicular notch of the manubrium sterni. The shaft of the clavicle is curved and its medial 2/3 is round and convex forward, and its lateral 1/3 is flattened and concave forward. The inferior surface of the shaft possesses a small longitudinal groove in its middle third. This table shows the muscles and the ligaments attached to the clavicle. The muscles are pectoralis major, sternocleidomastoid, deltoid, trapezius and subclavius, and the ligaments attached are coracoclavicular, costoclavicular and the interclavicular. Let us move on to the last section of the short answer, which is the clinical correlation. Let us discuss about the fracture of the clavicle. The clavicle is the most commonly fractured bone in the body, and commonly fracture occurs at the junction of its lateral 1/3 and medial 2/3. The fracture at this junction occurs because this is the weakest site and 2 curvatures of the clavicle meet at this site. The transmission of forces due to the impact from the scapula to the clavicle occur at this site through the coracoclavicular ligament. Now let us move on to the last short answer of the upper limb, which is the serratus anterior. Now I'll be explaining you serratus anterior in a form of a diagram. To give a very brief introduction, the serratus anterior is a broad sheet of muscle that closes the side wall of the thorax, and it is not a muscle of pectoral region. Let us move on to its origin. So this is the origin, and it arises by a series of 8 digitation from the upper 8 ribs, and the first digitation arises from the first and the second ribs, whereas all the other digitation arise from their corresponding ribs. Let us move on to its insertion. It is inserted into the costal surface of the scapula along its medial border. The first 2 digitations are inserted in the superior angle, the next 2 digitations into the medial border, and the lower 4 to 5 digitations into the inferior angle of the scapula. Under serratus anterior, we will be discussing about its introduction, origin, insertion, nerve supply, action, and its clinical correlation. To start on with its introduction, the serratus anterior is a broad sheet of muscle that clothes the side wall of the thorax and not a muscle of pectoral region. To move on to its origin, it arises by a series of 8 digitation from the upper 8 ribs, and the first digitation arises from the first and the second ribs, whereas all other digitation arises from the other corresponding ribs. Let us move on to its insertion. It is inserted into the costal surface of the scapula along its medial border. That is, the first 2 digitations are inserted into the superior angle, the next 2 into the medial border, and the last 4 or 5 digitation into the inferior angle of the scapula. Serratus anterior is supplied by the long thoracic nerve C5 to C7. To move on with its action, it is a powerful protractor of the scapula. That is, it pulls the scapula forward around the chest wall. For pushing and punching movements is required during the boxing, so it's called as the boxer's muscle. It keeps the medial, which is the vertebral border of the scapula, in firm contact with the chest wall. Its lower 4 or 5 digitations, along with the lower part of the trapezius, rotate the scapula laterally and upward during the overhead abduction of the arm. Let us move on to the last section, which is the clinical correlation. Let us discuss about the paralysis of the serratus anterior. The paralysis of the serratus anterior involves the injury to the long thoracic nerve by stab injury or during the removal of the breast tumor, which leads to the following effects, which are protraction of the scapula, which is weakened, and the inferior angle and the medial border of the scapula become unduly prominent, particularly when the patient pushes his hand against the wall, and this clinical condition is called as the winging of the scapula. We will be uploading the most important previous year and most frequently asked MCQs on upper limb very soon. So please do subscribe our channel in order to get acquainted, and this is a chance where you can evaluate yourself on this topic. To upgrade and enrich your medicine in the fingertips, and to also get updated with the shortcuts and techniques, do subscribe our channel.